Block simulation 29. Same process, fresh set. Read the command first, scan the clues, build fast, lock and move. 20 questions, 30 minutes, clock starts now. Which statement about CO2 transport and the Bohr-Haldane effects is correct? A physiologist studies how CO2 produced by tissues is carried in the blood to the lungs. Read the command. Which CO2 transport statement is correct? Most CO2 as bicarbonate, carbonic anhydrase, chloride shift, boride shift, DO2 2H+, right shift, unload O2. Haldane O2 promotes CO2 release. CO2 is carried in the blood 3 ways: dissolved to 7%, bound to hemoglobin as carbaminohemoglobin 23%, and the majority 70% as bicarbonate. In the red blood cell, carbonic anhydrase converts CO2 and water to carbonic acid, which dissociates into H+ and bicarbonate. The bicarbonate exits into plasma in exchange for chloride. The CH-chloride shift and the H+ is buffered by hemoglobin. This is the main vehicle for getting CO2 from tissues to the lungs. The correct answer is B. Two reciprocal effects link O2 and CO2. The BOHR effect in metabolically active TZS, the high CO2 and low pH H+ shift the oxygen hemoglobin curve to the right, decreasing hemoglobin's affinity for O2 so it loads more oxygen where it's needed. The Haldane effect, the converse, in the lungs, when hemoglobin binds O2, its affinity for CO2 and H+ falls, prompting the release of CO2 from the blood to be exhaled. Bohr helps unload O2 in tissues. Haldane helps unload CO2 in the lungs. The bicarbonate dominant transport with the Bohr and Haldane effects is correct. What is the diagnosis and the key exposure? A 65-year-old former shipyard insulation worker has progressive dyspnea, pleuritic chest pain, and a pleural effusion. Imaging shows pleural thickening and plaques. Biopsy shows a malignancy of the pleura with psammoma bodies and cells staining for calretin. He has a long latency since exposure. Read the command, diagnosis, and key exposure. Insulation shipyard worker, pleural malignancy, calretinin, long latency, malignant mesothelioma, asbestos. This is malignant mesothelioma, a malignancy of the mesothelial cells lining the pleura and occasionally the peritoneum pericardium. The key exposure is asbestos, classically in shipyard workers, insulation construction workers, pipe fitters, and roofers, with a characteristically long latency of several decades between exposure and disease. It presents with progressive dyspnea, pleuritic chest pain, recurrent pleural effusions, and pleural thickening plaques. Tumor cells stain positive for calretin. The correct answer is E. A high-yield twist concerns smoking. Asbestos exposure causes both pulmonary fibrosis, asbestosis, with ferruginous bodies and increases the risk of bronchogenic carcinoma, and smoking multiplies that bronchogenic cancer risk synergistically. However, smoking does not increase the risk of mesothelioma itself. So a shipyard worker who smokes is far more likely to get bronchogenic lung cancer, but the pleural mesothelioma is tied specifically to the asbestos, not the cigarettes. The asbestos-linked pleural malignancy with calretin positivity and long latency is malignant mesothelioma. What is the diagnosis, the enzyme, and how is it distinguished from a urea cycle defect? A 6-month-old has failure to thrive, megaloblastic anemia that does not improve with B12 or folate, and orotic acid in the urine, but no hyperammonemia. The defect is in pyrimidine synthesis. Read the command, diagnosis, enzyme versus urea cycle defect, megaloblastic anemia, unresponsive to B12 folate plus orotic aciduria, no hyperammonemia, hereditary orotic aciduria, UMP synthase, versus OTC orotic aciduria plus hyperammonemia. This is hereditary orotic aciduria, a defect in pyrimidine synthesis. The enzyme is UMP synthase, which normally converts orotic acid to UMP, the precursor of all pyrimidines. When it is deficient, the body cannot make pyrimidines, so orotic acid ACC accumulates and spills into the urine, and the impaired nucleotide synthesis causes a megaloblastic anemia. The key clue is that this anemia does not improve with vitamin B12 or folate because the block is downstream of those vitamins in pyrimidine production itself, and there is failure to thrive. The correct answer is C. The distinguishing feature from a urease cycle defect is the high yield point. Ornithine transcarbamylase, Mortier-CC deficiency also causes orotic aciduria because excess carbamoyl phosphate from the stalled urea cycle is shunted into the pyrimidine pathway, but OTC deficiency comes with hyperammonemia. The urea cycle can't clear nitrogen. So, orotic aciduria plus hyperammonemia, OTC deficiency, urea cycle. Orotic aciduria plus megaloblastic anemia, it had hyperammonemia, it had hereditary orotic aciduria, UMP synthase. Treatment of orotic aciduria is oral uridine, which bypasses the block. The UMP synthase deficiency with megaloblastic anemia and no hyperammonemia is hereditary orotic aciduria. Which thalamic nucleus is matched correctly to its input function? A neuroanatomist asks which thalamic relay nucleus processes each type of sensory information before it reaches the cortex. Read the command which thalamic nucleus matches its function. VPL body, VPM face taste, LGN face taste, LGN vision, MGN hearing, VL motor. The thalamus is the great sensory relay, and each nucleus handles a specific modality. The ventral posterolateral nucleus, VPL, relays body sensation, pain temperature, spinal thalamic, and fine touch, proprioception dorsal column, medial lemniscus to the somatosensory cortex. The ventral posterior medial nucleus, VPM, relays face sensation via the trigeminal pathway and tasty, a memory aid, BPM makeup, face and munchies taste. The correct answer is Z. For the special senses, the lateral geniculate nucleus, LGN, relays vision from the optic tract to the calcarine primary visual cortex of the occipital lobe, lateral light. The medial geniculate nucleus, MEN, relays hearing auditory to the temporal cortex, medial music. And the ventrolateral nucleus, VO, is a motor relay, receiving input from the cerebellum and basal ganglia and projecting to the motor cortex. The trap options swap modalities. The VPL body, VPM face taste, LGN vision, MGN hearing, VL motor mapping is the answer. What is the diagnosis, the association, and an extra articular feature? A 24-year-old man has months of low back pain and morning stiffness that I improve with exercise, reduced spinal mobility, and decreased chest expansion. He is HLA-B27 positive, X-ray shows sacroiliitis, and later a bamboo spine. Read the command, diagnosis, association, extra articular feature. Young man, inflammatory back pain better with exercise, HLA-B27, sacroiliitis, bamboo spine, ankylosing spondylitis, uveitis aortic regurgitation. This is ankylosing spondylitis, a seronegative spondyloarthropathy, rheumatoid factor negative that typically affects young men. It is strongly associated with HLA, B27. The hallmark is eye inflammatory back pain, chronic low back pain, and morning stiffness that eye improves with exercise activity and worsens with rest, the opposite of mechanical pain. It begins with sacroiliitis and ascends the spine, where ossification of the ligaments and fusion of vertebrae produces the classic bamboo spine, with reduced spinal mobility and decreased chest expansion, costovertebral involvement. The correct answer is Z. The extra articular features are high yield. The most common is acute anterior, uveitis, a painful red eye. Also HLA, B27 associated. Cardiac involvement can cause aortic regurgitation, aortitis, and conduction block. Restrictive lung changes occur from limited chest expansion. It is part of the HLA-B27 pair group, psoriatic arthritis, ankylosing spondylitis. Inflammatory bowel disease, ankylosing spondylitis, ankylosing spondylitis, ankylosing spondylitis, inquire. Treat with NSAIDs, exercise, and TNF inhibitors. The HLA-B27 spondyloarthropathy with bamboo spine and uveitis is ankylosing spondylitis. Which statements about renal clearance are correct? A renal physiologist measures renal blood flow using clearance methods. Para-aminohyperate, PAH, is both filtered and secreted, while inulin is only filtered. Read the command which clearance statements are correct. Inulin clearance, GFR, PAH clearance, RPF, filtration fraction, GFR, RPF, D20 pers. Creatinine slightly overestimates GFR. Renal clearance principles let us measure kidney function. Inulin is freely filtered and is neither reabsorbed nor secreted, so its clearance equals the glomerular filtration rate GFR. It is the gold standard. Para-aminohyperates. pH is filtered and actively secreted, so that at low plasma concentrations near the ALL, the PAH entering the kidney is cleared into the urine in a single pass. Its clearance therefore approximates the effective renal plasma flow ERPF. From RPF, you can get renal blood flow by dividing by 1 monthly hematocrits. The correct answer is Z. The filtration fraction is the proportion of plasma reaching the kidney that gets filtered. FFWGFR, GRPF, normally about 20%. It changes with arteriolar tone. For example, angiotensin II preferentially constricts the efferent arteriole, raising GFR relative to RPF and thus increasing the filtration fraction. Clinically, creatinine clearance is used to estimate GFR, but because creatinine is slightly secreted by the tubules, it modestly overestimates the true GFR. The inulin equals GFR, PAH equals RPF, and FF equals GFR over RPF relationships are the correct statements. Which statement about vancomycin is correct? A hospitalized patient with MRSA bacteremia is treated with vancomycin, another with C. difficile colitis receives it orally. During a rapid infusion, a patient develops diffuse flushing of the upper body. Read the command, which vancomycin statement is correct. Inhibits cell wall, binds D-ala-D-ala, MRSA plus oral for C. Diff, red man, syndrome histamine, rapid infusion, resistance D, ala-D-lock. Vancomycin is a glycopeptide antibiotic that inhibits bacterial CEL wall synthesis, but by a different mechanism than beta-lactams. It binds directly to the D-alanyl-D, alanyl-D, alanyl-D, ALA, terminus of peptidoglycan precursors, sterically blocking their incorporation and cross-linking. It is bactericidal and used for serious, gram-positive infections, notably MRSA, methicillin-resistant staph, and other resistant gram-positives, and is given orally where it stays in the gut to treat C. differential colitis. The correct answer is C. The toxicities are testable. Redman syndrome is diffuse flushing of the face and upper body from nonspecific histamine release during rapid infusion. It is not a true allergy and is prevented by slowing the infusion and pre-treating with antihistamines. Other toxicities include nephrotoxicity and ototoxicity. Resistance develops when bacteria modify the binding target from D-ala-D-ala to D-ala-D-ala-D-alactate, which vancomycin can't bind, as in VRE. The D-ala-D-ala binding cell wall inhibitor with Redman syndrome and D-ala-D-lac resistance is the correct vancomycin profile. What is the diagnosis and the mechanism? A 40-year-old develops rapidly progressive dyspnea and hypoxemia one day after severe sepsis-high pancreatitis. Imaging shows bilateral diffuse infiltrates. The PaO2-VO2 ratio is low. There is no evidence of heart failure, normal wedge pressure. Lungs show diffuse alveolar damage with hyaline membranes. Read the command, diagnosis, and mechanism. Acute hypoxemia after sepsis, bilateral infiltrates, low PF ratio, normal wedge, hyaline membranes, hyaline membranes, ARDS, diffuse alveolar damage, increased permeability. This is acute respiratory distress syndrome, ARDS. It is triggered by a severe insult. Sepsis, the most common, aspiration, pancreatitis, trauma, massive transfusion, or pneumonia that causes diffuse alveolar damage. Inflammation injures the alveolar capillary membrane, dramatically increasing its permeability, so protein-rich fluid leaks into the alveoli. A non-cardiogenic pulmonary. A cell, protein-rich fluid leaks into the alveoli, a non-cardiogenic pulmonary edema. Damaged pneumocytes form HYA ion membranes and produce less surfactant, leading to widespread alveolar collapse. The correct answer is C. The physiology and diagnostic criteria are high yield. The result is stiff lungs, the female compliance, increased shunt, and severe hypoxemia that is refractory to supplemental oxygen, e.a. right to left shunt. Diagnosis: Berlin criteria requires ACUT onset, bilateral infiltrates, a low PaO2-VO2 ratio. The diffuse damage, non-cardiogenic edema with refractory hypoxemia, is AR. DRDS. DRD is pressure, distinguishes it from heart failure. Management is supportive with LAO. DRW, TRDL, volume lung protective, ventilation, and PEEP to limit further injury. The diffuse alveolar damage, non-cardiogenic edema with refractory hypoxemia, is ARDs. Which organism is responsible, and what are the treatment and prophylaxis? A patient with advanced HIV CD4 count 50 develops gradual dyspnea, a dry cough, and marked hypoxemia with diffuse bilateral interstitial infiltrates and a very high LDH. Silver stain of bronchoalveolar lavage shows disc-shaped cysts. Read the command: organism, treatment, prophylaxis. Advanced HIV, CD450, dry cough, diffuse infiltrates, high LDH, silver stain cyst, pneumocystis jirovecii, TMP, SMX, treat plus prophylaxis at CD420. This is pneumocystis jirovecii pneumonia, PCP, caused by an opportunistic fungus formerly classified as a protozoan. It causes pneumonia almost exclusively in the IMM immunocompromised. Classically aids patients with a CD4 count below 200. The presentation is a subacute, gradually worsening DRY cough and DYSPNEA with marked hypoxemia, diffuse bilateral interstitial ground glass infiltrates, and a characteristically E-elevated LDH. The correct answer is C. The diagnosis is made by staining bronchoalveolar lavage or induced sputum. Methenamine silver or immunofluorescence reveals the disca cup-shaped CY cystis. It cannot be cultured. The treatment and prophylaxis is trimethoprim sulfamethoxazole TMP-SMX for severe disease, low PaO2, high AA, gradient add corticosteroids. Prophylaxis with TMP-SMX is started when the CD4 count falls below 200, the key threshold, with alternatives like dapsone or atovaquone for sulfa-allergic patients. The CD4 under 200 opportunistic pneumonia with high LDH treated and prevented with TMP-SMX is pneumocystis jirovecii. Which statement about renal potassium handling is correct? A renal physiologist studies how the nephron handles potassium and how aldosterone affects it. Read the command. Which Kpros handling statement is correct? Principal cells secrete Kpros, reabsorb napros, aldosterone. Secretion, INAC, NAK, INAC. High Kpros, high flow, alkalosis, high flow, alkalosis, high secretion. Potassium is freely filtered and largely reabsorbed proximally, but the final regulation, what determines K plus E excretion, happens in the late distal tubule and collecting duct at the principal cells. These cells reabsorb sodium through the apical enox-C channel and SC-secreted potassium into the urine through apical K plus channels, powered by the basolateral NAK AT base. Aldosterone acts here. It upregulates ENOC and the NAK ATPs, increasing sodium reabsorption and therefore K plus E secretion and excretion, which is why hyperaldosteronism causes hypokalemia. The correct answer is Z. Several factors modulate K plus secretion. I increased by high plasma potassium, the main stimulus, also driving aldosterone. High distal tubular flow washes K plus away, maintaining the gradient. Y-loop thiazide diuretics waste K plus aldosterone and alkalosis. Aldosterone and alkalosis. Acidosis, K plus secretion, high H plus shift reciprocal. The alpha intercalated cells handle acid base, secrete H plus, not the primary K plus secretion. The principal cell K plus secretion driven up by aldosterone, high plasma, K plus, flow, and alkalosis is the correct statement. What is the diagnosis? A 50-year-old woman has episodic syncope, constitutional symptoms, fever, weight loss, and a tumor clot with a mid-diastolic murmur that changes with body position. Echo shows a pedunculated mass in the left aurium attached to the septum. Histology shows scattered cells and a myxoid stroma. Read the command. Diagnosis: left atrial pedunculated mass, positional syncope, tumor plop, constitutional symptoms, myxoid stroma, atrial myxoma. This is an atrial myxoma, the most common primary cardiac tumor in adults. It is a benign neoplasm that most often arises in the left atrium, typically as a pedunculated stalk gelatinous mass attached to the interatrial septum, near the fossa ovalis. Histology shows scattered stellate or globular cells within an abundant MYXOID, mucopolysaccharide-rich stroma. The correct answer is B. The clinical clues follow from a mobile mass on a stalk. It can intermittently obstruct the mitral valve, causing positional body position, dependent syncope, dyspnea, and a mid-diastolic murmur with the classic tumor plop sound as it prolapses. It can embolize fragment stroke, systemic emboli, and it often produces constitutional symptoms, fever, weight loss, elevated inflammatory markers, because myxomas secrete IL-6. In children, the most common primary cardiac tumor is instead a rhabdomyoma, associated with tuberous sclerosis. The pedunculated left atrial mass with positional obstruction and a tumor plop is an atrial myxoma. Which statement about genital duct development is correct? An embryologist studies how the internal genitalia differentiate in male versus female fetuses. Read the command. Which genital duct statement is correct? Males, Sertoli MIF regresses Müllerian, late-egg testosterone develops Wolffian epididymis, vas-seminal vesicles. Females, Müllerian uterus stoops Schupper vagina. Internal genital differentiation depends on two testicular products in the male. Sertoli cells secrete Müllerian inhibitory factor MIF, also called anti-Müllerian hormone, which causes regression of the Müllerian paramesonephric ducts. Leydig cells secrete testosterone, which stimulates the Wolffian mesonephric ducts to develop into the male internal structures. The epididymis, vas deferens, and seminal vesicles, the seed, seminal vesicles, epididymis, ejaculatory duct, ductus deferens. DHT then forms the external genitalia and prostate. The correct answer is A. In the female, there is no testis, so no MIF and no testosterone. Without MIF, the Müllerian ducts persist and develop into the uterus, fallopian tubes, cervix, and upper third of the vagina. Without testosterone, the Wolffian ducts regress. This explains key disorders. In androgen insensitivity, MIF still regresses the Müllerian ducts, no uterus, while the Wolffian ducts fail for lack of androgen response. The MIF regresses, Müllerian, testosterone builds, Wolffian, and Müllerian becomes. Uterus framework is the correct statement. What is the diagnosis, the dangerous late complication, and the treatment? A 45-year-old man with chronic heavy alcohol use, now hospitalized and not drinking for 2 days, develops tremor, agitation, tachycardia, hypertension, diaphoresis, and a tonic-clonic seizure, then visual hallucinations and confusion. Read the command. Diagnosis, late complication, treatment. Heavy alcohol use, abstinent 2 days, autonomic hyperactivity plus seizure plus hallucinations, alcohol withdrawal, delirium tremens, benzodiazepines. This is alcohol withdrawal. Chronic alcohol enhances inhibitory GABA and suppresses excitatory glutamate NMDA signaling. When alcohol is suddenly stopped, the brain is left in a state of neuronal hyperexcitability. The syndrome evolves on a timeline: early 6-24 hours tremor, anxiety, and autonomic hyperactivity, tachycardia, hypertension, diaphoresis, nausea, withdrawal, seizures, generalized tonic-clonic around 12-48 hours, and alcoholic hallucinosis around 12-24 hours. The correct answer is A. The dangerous LAT complication is delirium tremens DT at 4896 hours. It is the most severe form, marked confusion, delirium, vivid hallucinations, agitation, fever, and severe autonomic instability, and can be fatal if untreated. Treatment of alcohol withdrawal across the spectrum is benzodiazepines, diazepines, EAG, diazepam, lorazepam, chlordiazepoxide, which substitute at the GABA receptor and prevent progression to seizures in DTs, add thiamine to prevent Wernicke, supportive care, and electrolytes. The autonomic hyperactivity to delirium tremens syndrome treated with benzodiazepines is alcohol withdrawal. What is the diagnosis, the enzyme, and how is it distinguished from its cherry red spot cousin? A 6-month-old of Ashkenazi Jewish descent has progressive neurodegeneration, a cherry red spot on the macula, and hepatosplenomegaly organomegaly. Foam cells are seen. The deficient enzyme breaks down sphingomyelin. Read the command, diagnosis, enzyme versus cousin. Cherry red spot plus hepatosplenomegaly plus foam cells, sphingomyelinase, Niemann, Pick versus Tay-Sachs, no, hepatosplenomegaly. This is Niemann, Pick disease type A, a lysosomal storage, sphingolipidosis disorder, autosomal recessive, more common in Ashkenazi Jewish infants. The deficient enzyme is sphingomyelinase, so sphingomyelin accumulates in lysosomes throughout the body. This produces progressive neurodegeneration, loss of milestones, hypertonia, a cherry red spot on the macula, and characteristic hepatosplenomegaly with lipid-laden foam cells, foamy macrophages in the marrow and organs. The correct answer is B. The high-yield distinction is from Tay-Sachs disease, its cherry red spot cousin. Both cause a macular cherry red spot and neurodegeneration in Ashkenazi infants, but the discriminator is organomegaly, Niemann, Pick, has hepatosplenomegaly and foam cells, whereas Tay-Sachs does not have hepatosplenomegaly. It is a hexosaminidase A deficiency with GM2 ganglioside accumulation and features an exagersaminidase, a deficiency with GM2 ganglioside accumulation and features an exaggerated startle hyperreflex, enomegaly, Niemann, Pick has hepatosplenomegaly, Niemann, Pick has hepatosplenomegaly, Niemann, Pick has hepatosplenomegaly, Niemann, Pick Noman, picks his nose with his finger, the sphingomyelinase. The sphingomyelinase deficiency with cherry red spot and hepatosplenomegaly is Niemann-Pick disease. What is the diagnosis and the embryologic origin? A 10-year-old has headaches, vomiting, and bitemporal hemianopia. MRI shows a CY cystic, calcified suprasellar mass above the pituitary. It is derived from remnants of an embryonic structure, and the cyst contains machinery motor oil, like fluid with cholesterol crystals. Read the command, diagnosis, and embryologic origin. Child, bitemporal hemianopia, cystic calcified suprasellar mass, motor oil fluid, craniopharyngioma, Radke's pouch. This is a craniopharyngioma, the most common suprasellar tumor in children, though it has a second peak in older adults. It is benign but locally aggressive. Its embryologic origin is the key fact. It derives from remnants of Radke's pouch, the oral ectoderm invagination that normally forms the anterior pituitary. Radiologically and grossly, it is cystic and calcified, and the cyst classically contains thick brownish machinery oil, machinery oil, fluid rich in cholesterol crystals. The correct answer is E. The symptoms come from its suprasellar location pressing on adjacent structures. Upward forward growth compresses the optic chiasm, producing bitemporal hemianopia, loss of peripheral vision, the crossing nasal retinal fibers. It also compresses the pituitary hypothalamus, causing endocrine deficiencies, growth failure in children, diabetes insipidus, and raised intracranial pressure headache, vomiting chromo. Histology shows wet kerata. It is distinguished from a pituitary adenoma, which arises from the adenohypophysis itself and is usually not calcified. The calcified, cystic, Radke pouch-derived suprasellar tumor compressing the chiasm is a craniopharyngioma. Which sequence of excitation-contraction coupling is correct? A physiologist studies how a skeletal muscle fiber converts a nerve signal into contraction. Read the command which EC coupling sequence is correct. A P and T tubule, LSRK tubules release secant tubules binds troponin, secant troponin C, tropomyosin moves, myosin actin crossbridge, ATP, circa relaxation. Skeletal muscle excitation contraction coupling proceeds in order. An action potential travels along the sarcolemma and down the T-tubules. This depolarization triggers release of calcium from the sarcoplasmic reticulum via the ryanodine receptor. The released K2-PU bonds troponin C, which causes tropomyosin to shift away from the myosin binding sites on actin, exposing them. Myosin heads then bind actin, forming cross bridges, and pull the thin filaments inward, the power stroke, shortening the sarcomere. The correct answer is A. ATP is essential at 2 points, a common test trap. ATP binding to myosin allows it to detach from actin, releasing the crossbridge, and ATP hydrolysis recocks the head for the next stroke, which is why ATP depletion after death causes rigor mortis. Myosin stays bound. Relaxation occurs when calcium is actively pumped. BACKTU, the sarcoplasmic reticulum, by SRKACTPS, ATPase. So CTPase leaves troponin and tropomyosin recovers the sites. The T-tubule to SR calcium to troponin C cascade with ATP dependent cycling and SRK relaxation is correct. Which stone type is most common and which is associated with alkaline urinate-urase organisms? A 30-year-old man has recurrent episodes of severe colicky flank pain radiating to the groin with gross hematuria. CT shows a 5mm reader. Urinalysis shows envelope shape or coffin lid crystals, and his urine is the typical type associated with the most common stone. Read the command, most common stone, and the alkaline uracing one. Calcium oxalate, most common, radiopaque, envelope crystals, struvite alkaline urine, urese organisms, proteus, staghorn, uric acidic, radiolucent. This is nephrolithiasis presenting with classic renal colic, severe, colicky flank pain radiating to the groin with hematuria. The stone types are high yield. Calcium oxalate stones are the most common, about 75–80%. They are radiopaque Q, form envelope or dumbbell-shaped crystals, and arise from hypercalciuria, hyperoxaluria, including ethylene glycol, vitamin C excess, Crohn's disease, or hepatituria. Calcium stones tend to form in normal. To acidic urine, the correct answer is A. The other types, STRA-Vitae, magnesium ammonium phosphate stones, form in alkaline urine produced by urease, positive organisms, proteus, Klebsiella, Staph saprophyticus, which split urea into ammonia, raising the pH. These form large staghorn calculi coffin lid crystals. Uric acid stones form in acidic urine, gout, high cell turnover, hyperuricemia, and our radiolucent need ultrasound CT, not plain X-ray, treat by alkalinizing the urine. Cystine stones occur in cystinuria, hexagonal crystals. The calcium oxalate, most common, and struvite from urease. In alkaline urine facts are the answer. Which drug class and reaction are these, and what is the antidote? During general anesthesia, a depolarizing neuromuscular blocker is given. Soon after, the patient develops a rapid rise in temperature, severe muscle rigidity, tachycardia, and hypercarbia. There is a family history of anesthetic complications. Read the command, drug class, reaction, antidote. Depolarizing blocker, succinylcholine, hyperthermia plus, rigidity plus family history, malignant hyperthermia, RYR1, dantrolene. The drug is succinylcholine, a depolarizing neuromuscular blocker. Unlike the non-depolarizing agents, the coronium curium drugs, which competitively antagonize the ACH receptor, succinylcholine is an ACH receptor agonist that causes persistent depolarization. It produces brief fasciculations and then flaccid paralysis, phase I, because the receptor stays depolarized and cannot reset. Note, its block is not reversed by cholinesterase inhibitors in phase I. Giving neostigmine can worsen it. The correct answer is B. The reaction is malignant hyperthermia, a life-threatening pharmacogenetic emergency triggered by succinylcholine, an inhaled volatile, anesthetics, halothane, etc., in susceptible people with the ryanodin receptor RYR1 mutation, autosomal dominant, hence the family history. The trigger causes uncontrolled calcium, release from the sarcoplasmic reticulum, driving a hypermetabolic state, severe muscle rigidity, rapidly rising temperature, tachycardia, hypercarbia, and acidosis. The antidote is dantrol, which blocks the ryanodine receptor to stop the calcium release, plus cooling and supportive care. The succinylcholine triggered malignant hyperthermia treated with dantrolene is the answer. Which virus is responsible and why these varied presentations? A 5-year-old has bright red slapped cheeks and then a lacy reticular rash on the arms. Separately, a patient with sickle cell disease develops a sudden aplastic crisis, reticulocytopenia, and a pregnant woman's fetus develops hydrops fetalis. The virus infects red cell precursors. Read the command. Which virus and why varied presentations? Slap cheek plus aplastic crisis and sickle cell plus hydrops fetalis infects RBC precursors, parvovirus B19. This is parvovirus B19, the smallest DNA virus, a naked single-stranded DNA virus. The unifying mechanism behind its varied presentations is that it infects and destroys erythroid precursors, red cell progenitors, in the bone marrow, by binding the blood group P antigen, globicide, on their surface, transiently halting red cell production. The correct answer is E. The 3 presentations follow from that. In healthy children, it causes erythema, infectiosum, fifth disease, the bright red, slapped cheek rash, followed by a lacy reticular rash and arthralgias in adults. In patients with chronic hemolytic anemia, sickle cell, hereditary spherocytosis who depend on brisk red cell production, the temporary shutdown causes a sudden aplastic crisis with reticulocytopenia, and in pregnancy, fetal infection can cause severe anemia and HY drops fetalis. The single naked DNA virus that infects red cell precursors, producing slap cheek disease, aplastic crisis, and hydrops, is parvovirus B19. What is the immunodeficiency and the molecular defect? A male newborn has delayed separation of the umbilical cord, 30 days, recurrent skin and soft tissue infections, Whithout pus formation, poor wound healing, and a markedly elevated blood neutrophil count. Neutrophils cannot exit blood vessels to reach infection sites. Read the command. Immunodeficiency and molecular defect. Delayed cord separation. Infections without pus, high neutrophils, can't extravasate. Leukocyte adhesion deficiency type 1, CD1. This is leukocyte adhesion deficiency type 1, LAD1. The molecular defect is in the beta-2 I-integrin subunit, CD1T, part of LFA1-MAC1, an autosomal recessive deficiency. Integrins are what allow rolling neutrophils to firmly adhere to the endothelium and then extravasate migrate out of the blood vessel toward a site of infection. Without functional CD18 integrins, neutrophils cannot leave the bloodstream to reach tissues. The correct answer is E. The clinical triad is classic and explained by that single defect. Delayed separation of the umbilical cord beyond 30 days. Neutrophil-mediated tissue remodeling is impaired is the signature clue. Recurrent bacterial skin and mucosal infections occur without pus at tis to form pus and meet the tissue to form pus, and with poor wound healing. And because the neutrophils are stuck in the circulation, unable to marginate exit, the blood shows a markedly elevated neutrophil count, leukocytosis. The CD18 integrin defect causing failed neutrophil extravasation, delayed cord separation, plus reinfections, and high blood neutrophils is leukocyte adhesion deficiency type 1. Block 29 is done. Let's review the 5 biggest traps from this block. Trap 1. The Bohr effect is in the tissues. High CO2 and H plus shift the oxygen curve right so hemoglobin unloads oxygen. The Haldane effect is in the lungs. Binding oxygen makes hemoglobin release CO2. Don't reverse them. Trap 2. Orotic aciduria with megaloblastic anemia and no hyperammonemia is hereditary orotic aciduria from UMP synthase deficiency. Orotic aciduria with hyperammonemia is OTC deficiency in the urea cycle. The ammonia level splits them. Trap 3. Mesothelioma is tied to asbestos exposure with a long latency, and smoking does not raise mesothelioma risk. Smoking multiplies the risk of bronchogenic carcinoma instead. Keep those two asbestos cancers straight. Trap 4. Both Niemann, Pick, and Tay-Sachs give a cherry red macular spot in Ashkenazi infants. The difference is organomegaly. Niemann-Pick has hepatosplenomegaly and foam cells from sphingomyelinase deficiency. Tay-Sachs does not. Trap 5. Succinylcholine and volatile anesthetics can trigger malignant hyperthermia in patients with the ryanodine receptor mutation, uncontrolled calcium release, hyperthermia, and rigidity. The antidote is dantrolene, which blocks that calcium release. 29 blocks. 580 questions. Training process, not memorization. StepLogic, learn how to think, not memorize.